Hey everyone. So in this video here, we're going to talk about how we can use past injuries and past pain experiences to help guide our thought process and our decision making when we're trying to do a couple of things, when we're trying to make sense of an individual's current pain experience, particularly in cases when there's no clear mechanism of injury that you can pinpoint that led to the individual's experience of pain or injury. So if someone rolled over their ankle and now they're coming to see you with the current experience of ankle pain, then it makes sense as to why they are currently experiencing ankle pain. But if someone has gradually developed a pain experience or a movement limitation at the low back SIJ, for example, which is the example that we're going to use in this video, then if the individual can pinpoint an exact cause or an exact mechanism of injury that led to that pain experience, then we do need to dig into the individual's subjective history to help try and make sense of things. And it doesn't mean we're going to be able to clearly identify a cause, but we need multiple sources of information when we're dealing with an experience that is uncertain, that likely has emerged as a result of many contributing factors versus one root cause. And so the way that we approach that uncertainty is by gathering multiple sources of information. And one such source of information is the previous history of injuries and the previous pain experiences as well. And there's a number of ways that we can go about doing this. Generally, when we're looking at past injuries and pain experiences, we can do it through two different lenses. We can do it through a temporal lens and a spatial lens. I'd like to do it using both, but we're going to look at this spatially in this video, meaning we can map out the past injuries on a body chart relative to the individual's current pain experience, represented in red here. This would be the current pain experience. And in blue, we have represented the previous injuries, the previous pain experiences. And this helps us understand, at least from an IKM perspective, we have a general kind of model that we use to guide an overall thought process in terms of how the system is managing forces. And one key feature of that framework and that model that we use involves looking at the difference in roles that the limbs display and the midline displays within the context of handling forces from the external environment. And one key feature there is that the limbs have to experience force first from the external environment, because those are the structures that directly engage with the external environment. And so this gives us a better framework upon which we can use the individual's previous injury from a spatial standpoint to describe how we can make sense of their current injury with them and how we can educate them. Okay, so we'll talk about that across the course of this video, but how that would be different to an individual's education that we would give them from a temporal standpoint would revolve considering the time at which the individual sustained previous injuries. So, for example, let's say this individual had developed left low back pain, SIJ pain, in 2023, and in 2022 they had just experienced an ankle sprain, which led to them moving differently. The body had to adapt to that pain experience, and as a result, the lower limb changed the way it's been experiencing forces. So, on a temporal level, we could consider that the previous injury at the ankle led to a change in how that lower limb was handling and generating and sharing forces, which may have influenced the behavior of the proximal tissues around the lumbar spine, and may have influenced the sensitivity or the tolerance to stress and forces at that proximal region. Okay, so naturally there's going to be an overlap between a temporal viewpoint and a spatial viewpoint, but a spatial viewpoint requires a body chart that you can actually have the clients map out themselves, or you map them out. Typically, I'll do this in clinic where I'll have the client tell me their information. I'll map that out on a body chart and use that to have a conversation with the client as to what may have contributed to their current pain experience. And again, it's important to consider that past injuries and past pain experiences are only one source of this information. Okay, we can't rely on that information, because there will certainly be situations where you're asking a client about past injuries and previous pain experiences, and they don't have any relevant ones. And so you can't necessarily use that information as a component of your education through which you're trying to make sense of the individual's current symptoms. One thing to get into here first is, again, how do these past injuries, these past pain experiences inform our assessment and rehab? Okay. Again, it's important, like I said, to use these pieces of subjective information. Again, they're unique to the individual, particularly in cases when it's been more of a gradual onset of pain and injury. And another key thing to consider there is there a difference to the client from an injury perspective versus a pain experience perspective? Because oftentimes you might have had this experience as well with clients, is when you ask the client about previous injuries, relevant to their current experience of pain. So again, if someone comes to see you with a current experience of left-sided low back pain, again, a previous injury of a thumb fracture, for example, might not be relevant or might not matter in terms of their current pain experience, but relevant injuries and pain experiences would be those that would be experienced across the midline or across the lower limb, particularly, okay, from a relevant standpoint. But what's important to consider there is that when you ask a client about their previous injuries, very often their mind will jump to things that are more traumatic, like a surgery or like an actual trauma where they've broken a bone or they've damaged a structure or tissue. They've experienced some kind of structural damage or change or trauma to the system, okay? And they forget to consider previous pain experiences or areas that they frequently experience intermittent discomfort, for example, okay? Now, we're not going to get into that in too much detail in this video, but this can be important, for example, if you have a client that, let's say they have a current experience of right shoulder pain and it gradually developed, they don't have, and you ask him about previous injuries, and they say, no, never had broken a bone, never had any kind of issue at all. But then you ask him, is there any areas across the neck, spine, upper limb, arm, where you have experienced discomfort or ongoing tension, stiffness, for example? And they say, yeah, I always have a nagging ache in my neck and I experience intermittent headaches. So while that might not be directly related to the shoulder, that may encourage you to consider the movement variability around the neck. So for example, if there's a lack of variability around the neck, secondary to a change in muscle behavior, muscular stiffness, for example, then that may contribute to a change in the tolerance at the shoulder, for example. Again, it just gives you information through which you can use to try and make sense of the current symptoms, the current pain experience. It does not mean you're trying to be certain about one. You're not trying to be certain about a causal link between one and the other, but you're trying to entertain potential reasons for their current experience. Okay, and what that does, it actually gives you options through which you can have an influence over the client's current experience. Okay, it gives you something tangible upon which you can explain things through. Okay, instead of saying, "Oh, it depends." We always tend to use that term, it depends, but we still have to make a decision. So you can say it depends, but you still actually have to make a decision on what you're going to do from a rehab perspective. And so you need to have information upon which you can base those decisions on, okay? And again, trying to dig out injury histories and previous pain experiences can be really helpful in that regard. So I like to use this body chart to guide the education about how past injuries and pain may influence their current experience. And of course, this is more of a spatial representation, but I think it is helpful to clients that may not, connect the dots between previous injuries and their current pain experience from a temporal standpoint, meaning the time at which they were experienced. But when you look at things spatially on a body chart, and we can look at the limb and the previous injuries relative to their current pain experience, then sometimes it can make a bit more sense for clients. But of course, in reality, you're likely going to use both. Okay. So we're going to look at two examples here. So we have a left-sided low back pain and SIJ pain case inside here, but with two, let's say there are two individuals with the same location of current pain, but these two individuals have a unique injury history. Okay, Client number 1 has an injury history that extends across the lower limb, into the knee, into the ankle. And then client number 2 has more of a proximal injury history and pain experience. And I want to go through a process here of us hypothesizing and entertaining different reasons as to why or how these previous injuries may contribute to the current pain experience, but also how this may inform your decision making as to the entry point to rehab, how you're going to begin the rehab process, but also considering how might this influence how the rehab process may unfold, how the rehab plan may unfold. Okay, so case insight: we have a current left low back pain and SIJ pain experience, but the individual has a history of 2 meniscus repairs and multiple bilateral ankle sprains. Okay, now those injuries are distal to the current pain experience. But like I said initially, we like to look at things, particularly during the assessment process, from a very global standpoint. So one of those features involves looking at the midline relative to the limb. Okay, we consider that the midline region, the SIJ lumbar spine, doesn't directly interact with the external environment. The limb does. The limb deals with direct forces, contact forces, and those forces are distributed proximally. Okay, so the limb is designed in such a way to help it dampen those forces. Okay, so we could consider that if the limb doesn't possess the ability or the tolerance to handle those forces, then that can influence the tolerance level of the forces, or the tolerance level of the tissues and structures more proximally. Okay, particularly if that pain gradually developed. So from an assessment and rehab standpoint, we need to consider, is the distal limb low tolerance, the lack of tolerance from these previous injuries and pain experiences, influencing the tolerance at the lumbar spine? We also have to consider other things. Let's consider past rehabilitation. Let's say this client also went to see a previous therapist who did a lot of local work around the lumbar spine SIJ, and the individual didn't really experience any significant changes in symptoms. We have to consider there, well, does the individual need more proximal or local work around the lumbar spine, or is it a case where the lumbar spine is continuing to experience a lower tolerance to forces, leading to a pain experience, secondary to an inability of the lower limb to handle and generate forces and share those forces? So from a rehabilitation standpoint, we may have to direct our focus towards building the tolerance to load and the ability to distribute forces across the lower limb, secondary to those injury history, to those previous injuries, in order to have a long-term influence over the individual's current experience of left-sided low back pain and SIJ pain. And even going deeper into that, we need to consider, was there rehab done for these prior injuries? Was there rehab done for the left knee? Was there rehab done for the multiple ankle sprains? And if there wasn't, then we do need to consider that these previous injuries will influence the tolerance of those structures around the knee, around the ankle, to handle forces. Okay, and when force enters the system, when force enters your lower limb and your anatomy, it has to go somewhere. Okay, it doesn't just magically evaporate. It has to be handled somewhere. And so if certain tissues don't want to handle it, it's going to shift the demand onto other structures. Okay, and it's going to change your movement behavior as a result. We also need to consider the aggravating features. So let's say, for example, this client felt better at rest when they were sitting down, relaxing in bed. Generally at rest was fine. But during movement, when the limb had to be engaged with the environment, that's when they experienced a gradual onset of left-sided low back pain and SIJ pain. That strengthens this idea that perhaps the lower limb is struggling to handle those forces, and that's influencing the pain experience at the lumbar spine. So it helps us have this conversation with the client as to the importance of directing our focus to the lower limb. It doesn't mean we forget about the lumbar spine, but it changes our focus of attention. But we're making things individualized for them in order to have an influence over their current pain experience. Okay. Now let's contrast that with this previous injury, this injury history and pain experience. So same current left-sided low back pain, SIJ pain, but now the individual has a previous experience of an inguinal hernia repair and a lumbar discectomy. Okay, so these are more proximal surgical histories where there has been trauma to those tissues. And of course, we do need to consider, was a rehab done here? And if not, that's certainly going to influence how well those local structures are handling forces. But bringing it back to this idea of the limb versus the midline, because of the location of these previous injuries, we may hypothesize that perhaps just simply increasing the load tolerance and capacity across the lower limb here isn't necessarily going to have a direct influence on the tolerance level locally at the lumbar spine, simply because there hasn't been a history of injuries and pain experienced across the lower limb. Okay, so that may not be the key limiting factor that has contributed to this individual's current left-sided low back pain and SIJ pain experience. Okay, so maybe from an assessment and rehab standpoint, we need to consider whether there is more local muscular and joint variability limitations at the lumbar spine, pelvis, and femur. So are we seeing a limitation in a significant multi-directional limitations through spinal flexion, spinal extension into side bending in the frontal plane or the transverse plane? And maybe the individual is able to tolerate force as well across the lower limb. That's going to influence where you direct your focus early on. Okay, and of course, from a previous rehab standpoint, again, perhaps focus wasn't necessarily placed on restoring variability across these local structures. Okay, from an aggravating feature standpoint, which is another component or source of information that you can utilize from a subjective standpoint that the individual will tell you, consider if there's pain at rest versus movement. So oftentimes I find with clients that have these more local injury histories relative to their current pain experience. So again, the pain experience is currently at the lumbar spine, but there's a previous surgery at the lumbar spine, previous surgery at the left groin. I do tend to find that these individuals struggle more with lower intensity activities, because oftentimes I see when there's a lack of local variability, they may struggle to relax those muscular tissues at rest. Okay, so you often see that as a within the research as a representation of increased gain in the motor system, where there's less variability in the motor system, meaning when the individual is trying to rest, can the muscular tissues actually rest? Okay, whereas oftentimes with movement here, when you're moving now, when you're walking, they may experience a reduction in symptoms because now they're actually sharing some forces into the lower limbs. So they're actually distributing that stress across the lower limbs, or they're giving the lower limbs the opportunity to take on some of that workload, which may actually reduce some of the sensitivity at the lumbar spine, in which case you could hypothesize that maybe getting more load into the lower limbs is not going to be the thing that can influence this individual's current pain experience. I may have to direct a lot more focus towards restoring local variability around the pelvis, lumbar spine, thoracic spine, femur, for example, and all the relevant muscular tissues around there. Okay, so looking at this from a midline versus limb standpoint can be a really helpful starting point to help navigate their current pain experience and to inform your thought process and your decision-making process as to where you're going to start and how rehab may look, okay, across their entire process. Okay, so naturally, from our standpoint at IKN, we always want to work, particularly when we're dealing with proximal pain or injuries around the midline, for example, we're always going to want to work in a proximal to distal manner. So we're in that respect, we always want to restore the ability of the limbs to handle forces, generate forces, because the limb is a structure, the lower limb in this case is the structure that has to directly interact with the external environment and handle those forces. This gives the midline structure, the spine, the pelvis, the rib cage, thoracic spine, this gives the midline structures the opportunity to express more variability because the limb has taken on that role of handling those forces. But in these two examples here, these two case studies, this is going to influence the speed at which you work from proximal to distal. Okay, so in this example here, because of the history of injuries at the lower limb, and they have the current experience of pain at the lumbar spine, you may have to work into the lower limb much sooner in order to have an influence over the individual's current experience of pain. Whereas in this scenario here, you may work into the lower limb much later in the rehab process because you're going to direct most of your focus around the lumbar spine to restore variability to the pelvis, femur, rib cage, thoracic spine, the local area. And then you may progress into the lower limb after you've promoted that local variability, okay? Which is again different to this case scenario because we may not see, we certainly might see local limitations in motion, but the reason for that limitation may be the result of a lack of tolerance and capacity to forces across the lower limb, okay? So you can see the difference in thought process here between these two case scenarios, but I think it is a helpful one to utilize during the assessment process and to use to have a conversation with your client, particularly if the client has had previous rehabilitation experiences or previous treatment from different providers that have utilized perhaps more of a local treatment strategy in this case number one, particularly, and that hasn't really yielded positive results. Maybe they don't need a better local exercise or manual treatment around the lumbar spine. Maybe they just need to shift your focus away from that local area into the lower limb, for example. Okay, so hopefully that makes general sense. Again, I just touched on this proximal to distal progression idea. Generally, we want to restore the limb's ability to handle and generate forces. And again, we can consider how that may influence the speed at which we progress distally. Okay, so that is a key component of our overall rehab framework, is considering the role of the limbs relative to the midline. That is a general construct, a general concept, but that needs to be applied to the unique individual. So this is an example of how we can apply that general construct of midline versus limb behavior, but considering that within the specific context of the client's past injuries and past pain experiences. Okay, so like always, hopefully that helps guide your thought process. And of course, if you have any more questions, please let us know below.